Well, anyway, I'm Debbie Larson. I'm a hand therapist at the Norfolk and Norwich Hospital, and my interest at the moment is in preoperative screening to see if we can identify patients who are at risk of a poor outcome based on their thoughts and beliefs and pain attitudes. And I chose a uniform group in trapeziectomy patients. So for those of you who aren't aware, I talk about trapeziectomy because I see it all the time, and then I realize 99% of the population, 0.9, don't know what trapeziectomies are. So trapeziectomy is performed at the hospital, usually by orthopedic surgeons who are with a special interest in hands for osteoarthritis at the base of the thumb. It's a very common condition, more common in women than men, and a trapeziectomy is a simple excision of the trapezium, and that space then fills with scars, so you no longer have that painful articulation. The recovery is variable, so it's known to have a very good outcome at around 12 weeks, but just through anecdotal evidence, working with patients all the time, we know it's extremely painful to recover from, to the point where we tell patients that you're going to regret having the operation for the first 6 weeks. But then we have some high flyers that some patients do absolutely fine. So we thought it was a good group to look at and say, what is the difference between these people? There have been other studies looking to see why it's such a painful operation and what can be done in terms of changing surgical techniques. So there's been ligament reconstructions, tendon interpositions, where they try and fill that space and stabilize the base of the thumb and firing K-wires through it to stabilize it, compared to a simple trapeziectomy, and there was no difference at all between the two in terms of functional outcomes. And also there's been studies looking at the different splinting regimes afterwards. So are they better if they're immobilized, or are they better if they move early? And again, there's no difference. The evidence isn't high on that, but there doesn't appear to be any difference between what splint you use. So could it possibly be that it's based on the patient's, thoughts, beliefs, and their pain attitudes? So I was inspired by a course I took here at the UEA on pain management, and that's where I learned about the Start Back program. And if you're a physio, you're probably very familiar with this, but as an OT working in hand therapy, I'd never heard of it before. So Start Back is a program of research that's being conducted at Keele University. And they've done some very clever research looking at taking the most predictive questions from the usual pain questionnaires, the hospital anxiety and depression scale, the pain catastrophization scale, and the Tampa scale of kinesiophobia, and they found, and a question on bothersome, and they found 5 questions seem to be most predictive of whether somebody had a good or a poor outcome based on standard treatment for low back pain in primary care. So I thought this was good. Working in a busy hospital, you want a quick and easy tool to administer that will maybe give you a snapshot of how that patient will do. So I called Keele University, and they're very happy for me to administer it to a surgical population. They're very much interested in its use in primary care, and they're currently conducting a study looking at general musculoskeletal conditions. But they said go for it, just keep us informed. So what I'm doing is I'm giving these patients this questionnaire to 136 participants I need, who have been listed for a trapeziectomy. So every month I just look up the codes for trapeziectomy. I know who's been listed, and it's all been approved, all the ethics, R&D, I'll say that now. And the surgeons are all agreeable to this. And I send them this package of questionnaires that includes the generic condition screening tool, these 5 questions, the QuickDASH, the PEM, and a visual analog scale. And I also ask them a question, just a free text one: is there anything in your life that you feel may impact your recovery, whether it be they have to get back to work, or they're a carer for a relative, or that kind of thing. So they get that package preoperatively. Then I get an idea that then divides them up into high risk or low risk. So on that 5 items, if they score 4 or 5, that's where they're ticking yes to, I feel my pain will never get better and it's terrible. Then they're the high risk group. If they score 0 to 3, they're in the low risk group. So then the idea is I then track these people at 6 weeks, and that's where we find people are still really painful or okay. 16 weeks, that's our average time for discharge from hand therapy, where people are reaching a natural kind of conclusion to their healing, and they're plateauing and they're happy to manage on their own on average. And then just say, does it all wash out at the end anyway? It doesn't really make a difference at a year. Yep, that covers that one. So I'm a year into this study, but the inclusion criteria is males and females over the age of 40 with first CMCOA, having a trapeziectomy in orthopedics, although I accidentally recruited someone through plastics the other day, so I sent them an email saying, oh, just let you know about this study. They very rarely do trapeziectomies, but apparently they do some. And I've included patients receiving additional procedures, so if they're also having carpal tunnel decompression or trigger finger release, that wasn't a reason to exclude them. And if they are, for some reason, having additional stabilizing procedures, such as the ligament reconstruction, tendon interposition, I'm including all those because studies say it doesn't make a difference, so actually that shouldn't impact the outcome. But actually I am just purely looking at their pain attitudes. I just did for exclusion criteria the usual for questionnaires, just insufficient language skills or cognitive skills to complete the questionnaires, and I've excluded 2 so far for those reasons. So I don't have results because I'm not that far in, but I can tell you some information that I've gathered so far in my experience to date. It's been a really good population. We've had this experience with Tina previously with the Dubitrin's population, that it's an elective procedure. The patients have time to think about it and to consent. They're retired, they live in Norfolk, they're quite happy to help out, and they're often might be coming back for the other side, so they really want us to be doing more and doing well at what we do. The leaflet is given by a surgeon in clinic, so that's called pre-contact. So when the patient is listed for trapeziectomy, I've stapled my Getting Better leaflet to the front of all of the trapeziectomy information leaflets, so that the patients are aware that this study package will be coming to them. It's all postal, so there's no need to get hospital staff involved, which dramatically it complicates things. I made sure I had good quality printing. It was all quite expensive. It spent about £1,500, and I got funding through the Hand Research Fund for this. Stamped addressed envelopes are included, and nobody likes to waste a stamp. And minimal reliance on busy staff. So the unhelpful factors are that we lost a hand surgeon last year to clinical director, so there weren't as much of a throughput last year, and there's actually quite a wait list building up. But then we hired a new surgeon, and they rapidly are back up on track again. And my initial reliance on secretarial staff contacting me to let me know when people were being listed was inconsistent, so that's when I started getting the access to the trapeziectomy list myself, so that I could just do it myself. And then patients come off the list quite regularly, so I've got everyone who's listed, and then I'll be tracking them, and they're not having an operation, and then I'll see, and I'll contact the secretaries, what's happened to this person. Oh, they have an unwell relative, it's not a good time for them to have an operation, or they're medically unwell at the moment, or their thumb pain has got better. So there are many reasons why they then don't go on to have the operation, even though they have consented to the study. They do come off. So my recruitment has been very high. This is from so the year follow-up. So these are the results at the end of April. So more have been recruited since, but 40 have been invited, and we've had a dramatic increase in. So it's now up to 69. I need 130. I think it's 136 actually. 31 had consented of the 40 that were invited. 4 were then removed from the wait list. One had a different procedure than what they were listed for. 5 of the 31 just didn't return the package, but the response rate overall was 78%, which if you compare to GP surveys is 61%, so I'm getting a good response rate, recruitment rate for this. Stratification, so the patients are stratified into high risk and low risk group according to the generic condition screening tool, which I mentioned earlier. And I'm getting a good split that is actually very similar to the back pain. So I have the low risk group is 58%, and the high risk group is 42%, which gives me really 2 nice groups to compare over the year. So I'm quite pleased with that. And what's interesting is that the generic condition screening tool is there's no in between. They're either at risk or not. So I've found that quite an interesting thing to observe. Nobody seems to score a 3. Between the 2 groups to date, and again, there's not enough numbers to really say anything significant about this, but the ages between the low risk and the high risk are not too dissimilar. So low risk are 67 and high risk is 65, so the high risk is actually younger. Males to females in the low risk group, there's the only 2 males who have consented to be in the study are in the low risk group, and 16 females and 13 females in the other. And this is the real difference for me, is the comorbidities. So I do keep track of that from the clinic letters. and the clinical areas, it has to be said, can be quite brief, so I'm probably not capturing all the comorbidities. But the low risk group have far fewer comorbidities, and the ones that they do have are not as severe. So carpal tunnel, or they have bilateral CMC, or OA, or De Quervain veins, or diabetes. Whereas in the high risk group, there's depression, chronic fatigue, diabetes, cancer, renal transplants are the bigger ones. Low risk, live-in help, so both have someone at home to help them, was the question I asked, and 67% low risk and 69% high risk. Working, again, quite similar between the two groups. This is probably very reflective of the age population, that 22%, 23% are still working. And dominant hand, so the low risk group are having, fewer of them are having the operation on their dominant hand. So I have asked patients what will impact their recovery. Actually, I haven't asked that, things that will ease the recovery on the first question, the preoperative one. I do ask that on the 6-week, 16-week, 7-week, and they all mention hand therapy, which is great. It helps the recovery. But the predictors, again, this is very interesting. So the people who are at high risk are predicting problems. So they have demands at home. And again, I'm not interviewing them to get more information, so perhaps they both have the same problems, and the high-risk group are just very aware of it and reporting it, or they actually have a lot more demands on them, and that's why they're worried. But there's a very significant difference there. Pain is very similar. That's been quite interesting to me as well. And again, just looking at the information, the high-risk group has more pain, but I don't know whether it's significant or not. I don't have enough patients to say that yet, but not as far off as I probably was expecting. QuickDASH is higher in the high-risk group, and also the PEM is higher in the high-risk group. So they're starting off with greater reported disability. So far, 21 participants have had their operations. 20 have received their 6-week pack. 14 have received their 16-week pack. And 2 have received their 1-year pack. And I'm always waiting for more packages to come in. Some people are more prompt than others at returning their packages. And actually, I just sent off my first 3 1-year ones, which was great, and they've all returned them. So what's next? The obvious is, if we see that there's a difference and these people are recovering differently, then we need to probably provide some more supportive treatment for them, and then investigate the impact of that. And these are 2 studies. So Startback has a training program about integrating support for mental health in your everyday physical care, and there's another program as well going on at Guides in St. Thomas called Imparts that has another training program.